Thank you for tuning in to this episode of U of L's Online But Not Alone podcast. My name is Connor McCoyak, and I'm joined today by Dr. Lee Bewley of the University of Louisville's School of Public Health and Information Sciences. Dr. Bewley is the program director for U of L's online Master of Science in Health Administration. Both the MSHA program and the U of L School of Public Health were recently identified as being among the best in the nation, according to U.S. News and World Report. The topic of today's discussion revolves around the current state of healthcare administration. According to a recent Wall Street Journal article by Andrew Malika and Anna Wild Matthews, Americans spend more on healthcare than anyone else in the world. The article cited that insuring a family costs nearly $27,000 per year. Estimates on healthcare spending in the United States fluctuate between $4 and $5 trillion annually, more than double what the country spends on national defense. Despite this, the American Hospital Association reports that hospitals face ever-increasing challenges and financial pressure as they care for their patients. This begs a few questions. If healthcare spending is up, why are organizations under so much pressure? What does the future of healthcare administration look like as that pressure increases? And what does this mean for the MSHAs of the future? To explore these questions and more, I'd like to hand things over to today's guest. Dr. Bewley, thank you so much for joining us today.
Happy to be here. Thank you.
Yeah, absolutely. Please go ahead and introduce yourself, share a little bit about your experience, and then a little bit about the online MSHA program.
Happy to do so. I'm Lee Bewley. I have the privilege of being a native Kentuckian, seventh generation. Retired from the Army Medical Department and had an opportunity to come back home and join the faculty of the University of Louisville to develop the next generation of healthcare leaders to serve folks here, of course, in the Commonwealth of Kentucky, across the whole country and the world. To be able to provide effective and efficient utilization of resources into a better way. Look, I appreciate you. You noted that recently we were honored with very high rankings in U.S. News ranking reports, but it's honestly it's a member of a team. The faculty and the staff that we have in the School of Public Health and Information Sciences, our Health Management and System Sciences Department, our full-time faculty, our part-time lecturers, our staff, we have an excellent group of folks that are dedicated to serving the students. In our program, we see our students as our prime exemplars. We have publications, we have research and grants, but when we see our students go out and do great things in the workplace, serving their communities, those are our best credentials, and we're happy to celebrate them. A little bit about me, again, the farm kid from Kentucky, served in the Army Medical Department, came home to join faculty. My primary experiences first started as a combat health support officer. I transitioned to being a health administrator in federal Army healthcare facilities, including at home at Fort Knox, Kentucky, San Antonio, and Fort Sam Houston, Texas, Fort Hood. And I had a chance to be the administrator of a combat support hospital in Iraq. As a faculty member, my primary areas of emphasis are economics, strategic management, that are dedicated to developing healthcare leaders.
First of all, let me say thank you for your service. I don't know if I knew that about you or not.
Thank you. I was happy and privileged to be on a team. We were all dedicated to serving the American people, defending the Constitution, but honestly, it's service, providing for others in a way that makes for a better world, whether or not that's healthcare or national security. It just feels good, to have that as an element, to make a living, to be able to make a life, be able to make a better world and a better experience for everyone that we're with. And so, yes, I was privileged to be on a team of dedicated professionals, and it's also good to be retired.
Yeah, I can imagine. Let's see, this would have been maybe last year or the year before, through some work that I was doing with U of L Health at the time. I was privileged to have a conversation with one of the officers of, I believe, the 5th Special Forces Group out of Fort Knox. And it's fascinating thinking about kind of these intertwinements that healthcare is having with so many different industries across the world, not to exclude military now. In their instance, that was about the Special Forces operators learning about trauma response, because U of L Health's trauma center is one of the best in the nation. And it was fascinating for them to have that opportunity to learn from current trauma surgeons and trauma practitioners. And then also for them to learn a little bit about what our soldiers are running into downrange. And it was a fascinating conversation.
Connor, let me just say two things about this. On my time in the military, specifically in the Army Medical Department, there's two aspects of healthcare in terms of military service. is a couple. One is there's the practical elements. We want to save lives. If one of our teammates are downrange or on a training environment and they're injured or hurt, we want to save their lives. We need to ensure that we bring them home. We have a commitment to providing world-class care, literally Walter Reed style here in our own country, but to the battlefield. The other element of it is that we want to conserve the fighting strength. We need to be strong and ready and serve, quite frankly, as a deterrent that we have a fighting force that's ready to take care of our nation and take care of our responsibilities, in an international perspective. But let me also say this about healthcare, and it has a bit of an implication to the way our health system in the United States and our societies and our communities and our states. Healthcare can be a strategic resource and an asset. And so what we learned sometimes in the Army Medical Department, we might lead with healthcare at the tip of the spear, so to speak, that we might have healthcare professionals in a place that is austere, that is needing some type of intervention and support that doesn't come with specifically an M16 or an M1 Abrams tank. But how about a nurse or a family practice physician or a pediatrician or maybe even a plastic surgeon that can provide relief, or there's some type of preventative medicine disease or some type of environmental conditions in which our Army medicine team can provide an intervention, make a strategic impact, and to avoid a lot of the stress and grief and destabilizing effects that happen in this world that are health-related. And so I bring it back to our own country, our own system. Yes, we make all these investments in healthcare, but we've got to leverage that strategic resource to greater effect, to be able to have healthier lives, higher levels of productivity, greater fulfillment of our individuals, at a citizen level and at a community level, and to make that strategic, making healthcare sort of the tip of the economic spear here in the United States.
Well, I can't tell you how excited I have been for today's conversation. Like I said, I threw some of those numbers out at the very beginning. I think healthcare in particular, as I learn more and more about it and learn how increasingly complex that field is, I think there's incredible room for opportunity, but also several different challenges that the organization, the industry as a whole is kind of facing right now. So having said that, I'd love to jump into that first question that I had, which is, generally speaking, I know this might seem like a broad question, but what are some of your initial thoughts on the current state of health administration? What are some things that you're hearing from colleagues, alumni in the field right now?
So great question. In fact, I just recently came from the American College of Healthcare Executives annual Congress. I was down in Lone Star State in Houston. In some elements confirmatory in terms of trends, but also practical reality of what's happening in the healthcare and health systems field as it relates to the rest of the economy. And there's a couple of things, is that we are spending a substantial amount of resources per capita. I think our country is estimated about $15,000 per person that we spend for healthcare, but yet it's twice as much as other first world countries across the world, and our outcomes aren't as great. And then we have 10 to 20% of our population that we aren't regularly providing adequate access. And so we spend all these resources. We don't have outcomes that are as good or as effective as they could be, and we don't cover all of our people on a regular basis. And so, yes, we cover most of our people with excellent care. In an extreme emergency or a substantial medical event, we will save your life. We will spend a lot of resources and we'll get a good outcome on point, but yet systemically we could do better. The other element, and it's coming home to our whole system, is that we have a Medicare and a Medicaid program. Of course, retirees of the military health system or veterans have federal health care. We have Indian Health Service. But today, still, the basis for health care coverage in America is employer-based. A citizen, a person will have an employment at an organization, whether or not it's Ford or Apple Computer or could even be Norton Healthcare here in Louisville, Kentucky, is that the employment that you have comes with health care coverage. And so that is to say that your employer, through health insurance, are directly paying for health care, and a self-insured plan pays for your health care. In some cases, there might be some partnerships, some co-pays or deductibles. But here's the thing. For the past several years and the most recent year, the cost of employer-based health care has increased by double digits to 10%. And so the effect is that the cost of employment for the members of our team, our communities, our workforce is going up. It might seem like you haven't had a raise in a few years to a lot of employees, but yet their compensation is actually going up as a consequence of their employment status and the raising of healthcare costs. So there's two things. We've got all of these resources were dedicated. We have a case where costs are going up to employers, which is compounding either one, the organizational margins of employers out there, but it also feels like growth in your income is not going to employees. And then finally, and this is the thing that I think a lot of folks might say, look, we're spending nearly a quarter or a fifth of our economy in healthcare. Seems like everyone in healthcare systems are making so much money. The average hospital or health system in America is right at break even. In the past 3 years, the margins of health systems and hospitals have ranged from negative 0.4% to a positive 1%. And so right there at the break even, that's where our hospitals and health systems are. And so a point one way or the other, you might lose some county hospitals, or you might find that you see hospitals and health systems dialing back access to care. So that's where we're at right now. There's a lot of excellent care out there. It's high cost. We haven't covered everyone, and everyone, even through an employment basis, is being impacted by healthcare in some way.
That was one of the things that really surprised me, was seeing $4 to $5 trillion in annual spending on one industry. And I think to the point that you just made, I think a lot of people, if they don't know any better necessarily, might look at that and think that's got to be going to hospital overhead or provider overhead or other administrative costs. But our population is 330 million people in this country alone. And to your point, not all of them are necessarily covered to the extent that they should be. So it's a very complex issue that it doesn't seem like anyone has a
I
one
see
perfect answer for.
opportunity. Look, there are people that, comparatively speaking, have great earning power in healthcare. They earn it. They provide quality care, particularly the providers. Many of them working overtime, more than 40-hour shifts. We also have an aging of providers. We have a shortage of nurses and medical professionals across the field. And so strictly from an economic perspective, if you have constrained supply and you have ever-increasing demand, you begin to see costs go up. But what I also see, and I teach my students this, is that, look, the average medical administrator in America, average, median, which just includes senior executives and people that just graduated from a bachelor's degree program, right in the middle is about $118,000. And let's just say it plainly, that's a pretty good salary, and you'll earn it. But I tell my students this: if you could find a way to cost effectively manage your responsibility, whether or not it's a clinic or a department or a portion of a hospital or health system, you'll earn every bit of your salary 5 or 10 times over. And so the work of competent health administrators is to find a way to provide the appropriate level of resources to the providers to be able to provide quality care, to the standard that our community deserves, that our accrediting or credentialing bodies require, but yet in a way that enables a better margin in terms of the business sense, but also provides appropriate resources to effectively and efficiently achieve that quality effect. And from a society perspective, what that means is that we can begin to dial back costs that can either be utilized for other things like increasing your average pay or providing resources for bonuses, or for societally perspective, that we begin to have resources to expand coverage for those folks who can't provide for themselves.
Yeah, that's one of those things, I think, as people look into healthcare logistics in particular, so much of healthcare is about ensuring that you have the right healthcare provider with the right resources in the right place at the right time to get a specific patient outcome. That itself is a logistical, I won't say hassle, but it's a hurdle that needs to be overcome and identified.
There's a lot of logistics to it. The logistics can range anything from like new drug developments, like the advent of all of these GLP-1 medications. Look, and for some folks, having access to these resources will absolutely enhance their level of health. Did you know that the cost of someone who is medically obese, on average, is a little over $2,000 for the same medical condition per year? And so if we can find a way that we can channel resources like GLP-1 medications, which are costly and are increasing the cost across the board, in a way that we invest in the pharmaceuticals in a way to resolve better health issues, but also to resolve long-term chronic care conditions, we can make a case. So new technologies create costs, but there's also the frictions of compliance. There's also the frictions of trying to stretch the existing or legacy resources to reach even new and higher levels of access for healthcare beneficiaries.
That is something I'd love to hear you talk a little bit more about this, but that was something that occurred to me the other day, thinking about the GLP-1s in particular. because obesity is such an issue in this country, and if I certainly don't know, I'll leave that to your expertise, but there has to be a fairly high number of morbidities associated with obesity or causes of mortality associated with obesity, and I wonder what impact that's going to have.
Look, say, first of all, although I might have earned the expert field medical badge in the United States Army, I am not a physician. Right. I am not a dietitian. Of course, reviewed the literature sure. as far as everyone else. But brass tacks of the matter is that elevated levels of obesity come with higher levels of comorbidities. That empirical point of, I think it's $2,200 that studies generally show that the average cost per year for healthcare for those folks that are characterized in the obese range, all cost increase. But it also diminishes their capability and capacity to thrive, potentially reduces lifespan. And so if we can make those investments for those individuals, and let me just say this too, I think that there is room for partnership. People earn health care benefits through their employment. People are entitled to health care resources that if either they age into the Medicare program or their children, they can't provide for themselves. There's the Medicaid program, the VA benefits, Indian Health Service, DOD. We all come into a pool of resources, but there's also some personal responsibility that we have. And if we can give the people of our country, our citizens, our neighbors, the resources, and they have better understanding of how their choices and how the available resources can be matched to live healthier lives, it'll also likely increase the level of productivity in society, but also the enjoyment of these individuals to be able to have longer, healthier lives, which gets back to the original point is that we spend more than any other country, but yet our lifespans tend to be about 3 or 4 years shorter than other places. Wouldn't it be great to have another 2, 3, 5 years that we can, walk the Appalachian Trail, you spend some time with our grandkids or great-grandkids, or maybe even do something cool like walk the Great Wall of China or, go out to Madagascar and not just see it on a movie.
That was something I just came across in one of my courses was the some of the indirect benefits of appropriate levels of healthcare or provided through health administration. Certainly more productivity, increased lifespan. Something I just saw anecdotally, it was a Q&A with I forget who, but the idea was Europeans, what are some misconceptions about the United States that surprised you when you came to visit? And across the board, some of the things people were saying were Americans have this perception of being fat or being lazy or obese. And the reality, at least according to these Europeans, is that plenty of Americans are very preoccupied with their health. They pay attention to their diets. They look how much protein they're eating. They prioritize exercise. They know they don't get enough sleep. They're worried about their screen time. So I certainly think there's so much that health administration can do to enable people to live a higher quality of life, which will have downstream effects.
Look, I think the 21st century healthcare leader, and we advocate this for our students, you need to be as much a leader within your own organization as you are in the community. You should be able to have those levels of strategic communications with the people that you serve, those beneficiaries, those your patients, your neighbors. One part of it is stakeholder development, but the other part is just being a leader, setting a good example, making a point of communication as much as you have in your own organization, your clinic, your department, your hospital. Look, there's 3 things that people can do in response to leadership. One is resistance. Like, whatever you want to do, the other people are not going to go for it. That's a very, of course, bad place to be in terms of a leader. The other point is simple compliance. Like, I need or want you to do this, and that's all you do. Okay, got it. I will do it. And again, we're taking from an organizational or a societal or a community benefit. But the highest level of performance as a leader is when you can earn commitment. And that commitment means that whatever you're seeking to do, not only is the other folks, the people on your team within your organization or the people in your community, they're also equally bought in, and they may even do things above and beyond what you expected because they are similarly committed. And the way that you earn that commitment, and getting beyond just simple compliance, avoiding resistance, I think is to be competent. And as a competent leader is integral to being able to properly serve people. Look, there are a number of things that we focus on in healthcare in terms of our basic medical ethics or the way that you carry yourself as a professional. But ultimately, you aim to do good, and to avoid doing harm. You respect the autonomy of an individual, and you provide care and you provide services in an equitable and just manner. And I think that leader who develops those competencies, that, of course, your net present value calculations, you can conduct a Porter's value chain analysis. You can go through and conduct a analytic thinking diagram to be able to clearly understand the 3 courses of action and which one's most likely to succeed. Great. Those things are absolutely necessary. But when you can go to a person on your team, a member of your organization or a group of people, or even more from a healthcare perspective, out into the community, and you can make the case in a way that people understand, that they themselves can make great self-interested and publicly interested choices, I think we can get to a better place as a society, better place organizationally, and that comes from competent, invested leadership.
It's interesting to hear you say that because I was just thinking, healthcare administrators in particular, when you think about from a stakeholder analysis standpoint, they are leaders and they've got one of the more complex communication jobs that anyone could have. The stakeholders that you're engaging with could be all the way down to a patient level, all the way up to senior level leadership at a healthcare organization. So what would you, you already kind of touched on this a little bit, but what would you want to teach or educate or inform health administrators with regard to their communication? What are some things they can do well? What are some things they might do differently? How do they think about communication in 2026?
Look, the way I see things is that, first of all, you need to be able to take a systems perspective to the fullest extent. And we're all learning. Look, I'm 57 years old. I've served a full career in the Army Medical Department, work as a professional, and you should always be learning and seeking more to fully understand your environment and the things you're doing. So take a systems perspective, understand how do the interactive components of the United States healthcare system, to include the patient, the individual, all the way to the health system, the federal, state government, et cetera. But listen and get a sense of trends. We've got to find a way to harness the substantial data that's being generated by our patients, by our beneficiaries, with activities in health systems. Whether or not the encounters in the emergency room, a pediatric clinic, in a diagnostic laboratory, we need to take this information, collectively analyze it, trend, but also find a way to make decisions. We may even leverage the technology. When I say may, I absolutely believe that we're going to leverage the capabilities and capacities of artificial intelligence to extend the judgment and the decision-making capacity of human beings, for people, for healthcare leaders, to make decisions that are more precisely likely to be successful. Look, when we peer into the future, no one has a crystal ball. We can learn from the past. We can take the information and the data that we're getting in the moment, process it in a time-efficient manner, and then we make a choice or a decision, or we communicate to people. Again, when we're communicating within the organization to our own people, but also to the people that we're serving, you have to do so in a way that is understandable and that is compelling and that comes with the basis and standing of competence. Look, in our field, there's no fake it till you make it. In fact, anyone in healthcare that fakes it till you make it is likely to become famous because they are inappropriately practicing something that they shouldn't be. But look, an authentic, competent leader that understands the people that they're serving within their organization, taking a servant-based perspective in terms of your own organization, but also the community. You have to take the perspective of what's on the other side, that those people, that family. One part comes with empathy, another part comes with a humbleness, but the other part, I think, is you've got to have a positive effect. Take an achievement orientation. You may come to a successful organization, but you should strive to be even better. You might be put in a position where your organization, your community needs a lot of improvement. Make it better. Take that achievement orientation. Again, remain humble. Consider this who you're serving and what they're looking for in order to be able to rise beyond resistance and mere compliance, to get that commitment to a better way individually for better health, but more collectively, how can we improve and elevate the performance of our organization and substantially maintain or extend the level of health in our community?
Well, let's talk a little bit more about decision-making, especially as it relates to MSHAs. Just kicking it back to the articles that we mentioned at the very beginning, I think one of the things that health administrators have to think about right now with every decision they make is how that's going to financially impact the system overall, let alone their division or their unit. So I've got kind of a two-parter for you.
Yep.
What are some of the fundamental or ground level causes of the financial strain that healthcare systems are facing right now? And then knowing that, what are some things non-healthcare professionals might be surprised to hear about those decisions as they relate to health administration?
Well, look, the first element of why costs are so substantially high in our country One part is that achievement orientation. Whatever is the best, or that, achieves that level of satisfaction or expected outcomes of our American citizens, we expect it. And what comes with that, in many cases, is, earned benefits through your employment. And so I earned this. I expect to have that level of coverage. Or you age into it, or you have it as an employment benefit. We're talking Medicare, or if you are qualified for Medicaid coverage, of course, VA benefits, DOD, Indian Health Service, those federal programs have their own requirements. So if you have it, you expect the most of it. Our country also tends to be innovators and to come with novel techniques, new pharmaceuticals. And so we're sort of cutting edge. And so those new advancements come with their own level of cost. But it starts with the basis of expectations, is that our society expects to have high levels of performance, and they want to pay and they expect resourcing. But we are predicated on an economy that uniquely, perhaps the only exception might be auto insurance and auto repairs. The healthcare industry is the prime service or product in which the primary payer of the product or service received is not the person who actually receives that care. And so there's a certain level of price insensitivity that extends and enhances the level of coverage. The other element that are costly aspects is that we're all not fully covered. So we have a large part of our population, sometimes as much as 8 to 20%, that is either underinsured or not insured at all. And so that market basket of potential problems and issues build and surmount to a point where instead of having some preventative care earlier, like 1 or 2 or 5 years ago, it turns into an incredibly expensive and cost-constraining episode in a tertiary or acute care facility. You also asked, what are some things that might surprise you? I briefly addressed this earlier, is that we think that healthcare is a particularly lucrative or a profitable environment. A couple of things. One, the average hospital or health system in America is a nonprofit. The other element, again, I've told you in terms of the margin, is that we're operating as a hospital and health industry right at break even, which is to say that we're covering our cost. We may be drawing upon our reserves, but yet there's not a lot of dividends going around. But then again, with a nonprofit, the average organization in hospitals or health systems being nonprofit, is that even if you're cash flow positive or you have a profit, you simply put those away as a reserve for rainy day. Let me tell you about rainy days. The average hospital or health system, when they're seeing the most prevalent in terms of costly healthcare systems, is Medicare patients or Medicaid. Each one of those cases, on average, is a loss leader, which is to say that we lead in patients, we have that volume, but on point, there is hardly any margin, which is to say they may actually, hospitals or health systems, more likely to lose money on an inpatient care or some type of Medicare or Medicaid beneficiary patient encounter.
Healthcare in many ways kind of seems like a puzzle in that you're trying to navigate so many different levels of complexity, trying to make sure the right piece fits into the right place and making sure that it all works together cohesively. Something that I've read that health administrators are increasingly preoccupied with is process improvement, specifically through Six Sigma, lean management, agile management, all to try and find process improvements or efficiencies that they can pursue. And something I was kind of wondering, and I'd love to hear your thoughts on this, is what is an administrator to do when there's not much more you can really change for a process, or there's not really a refinement that can be made? Healthcare constantly needs to improve and optimize, but at a certain point, does it feel like there's no more fat to trim?
There's a great point. I think there's often attributed, don't let good or pretty good be enemies with excellent or perfect. And so rare will you find a perfect process, but you can find pretty good. And I do get your point, is that it seems as though you can apply Lean Six Sigma, quality processes, focused PDCA, and it seems as though on point within the system of patient care or sterilization of our surgical devices or how we onboard new employees in our healthcare systems, it's pretty good and very near excellent. And so this pursuit of excellence has never been about absolute perfect. And I bring 2 points to this. One is that an entire complex organization like a hospital or a health system, to take Michael Porter's value chain perspective, are all interconnected components. And so where those interconnected links in the value chain are really tight and strong, you probably have really good quality processes. You've either achieved them or you've benchmarked against best processes, benchmark against your competition. Where there's weak links, you can focus there. There's so many links is that a complex organization is constantly and perpetually maintaining quality processes, because over a period of time, some links may be particularly strong, but yet they could wither in time. And what wither in time means is that those strong nurses that you had 5 or 10 years ago have now aged into retirement, and they're being replaced by other folks. The cost constraints have maybe taken the ratios of our paraprofessionals or some of our administrative associates, and we've had to redistribute them. And so things are changing. And so, yes, I get the point that it does seem that you can declare victory. Somewhat reminds me of as a dad, The Incredibles, where Mr. Incredible laments that, my goodness, I saved the world all at once. Can it just say saved for a little bit longer? Why do I have to dive back in there? Well, that's the story with healthcare. Things are perpetually changing. And then even with the perpetually changing, let's just say your whole health system were to be at perfection or perfect top tier quality, to that 6 sigma 3 defects in a million, which would be pretty rare. We are still pair that against we're not serving all the people. And then you have to expand the capacity of your health system or your medical facility to be able to enlarge to the point that you are covering them. And then, of course, the world throws you a pandemic. The world demographically changes, or we have some type of financial shock. And so does the environment then stress that value chain linkages in a way that you have to respond? So great point. Yes, it can seem like Mr. Incredible saved the day, and we're very close to perfect and incredible, but yet things tend to change, and we need to be ready to make those adjustments. And so we can't rest on our laurels. We have to constantly and perpetually seek excellence and move to higher levels of quality.
Well, first things first, I've got to give you a tip of the cap. I think The Incredibles is criminally underrated as far as Pixar movies have gone. Something very interesting that you just mentioned, though, the world throws you a curveball like a pandemic. I think I can't tell you of the different people that I've interviewed how many people have a pre-COVID and post-COVID life that they try to remember. And interestingly, I think we're actually right on the verge of something similar. Depending on when you listen to this, the United States is in conflict with Iran. The Strait of Hormuz is closed. And if I'm not mistaken, I believe the world's oil reserves are starting to diminish. I don't know. Each country has a different long-term supply, but I think most of those supplies are starting to diminish, and there are going to be significant economic impacts to that if something like that does come to pass. Healthcare is not going to be any exception if things get spicy, for lack of a term.
I'll leave it there. Look, my health economics perspective is I won't go to world economies or whatnot, but brass tacks, even any base level economist can tell you that petroleum specifically is a critical energy source. Yes, the United States on point might be energy independent in terms of we're not a net importer, but the whole world depends upon access to energy. And so it could very well be that the oil that came from that part of this of the world that's currently under substantial war constraints goes into the production of something that you go to Walmart or Target or you get on Amazon and purchase that suddenly became more expensive because the cost basis that is derived ultimately from the prime driving force of energy has substantially been impacted. I'm hopeful that we'll work through it as a world and a society. But we have to be ready for these shocks. And anything that impacts health or energy, maybe throw education in there, is going to ultimately have second, third order effects, externalities. We hope for positive externalities that, hey, sort of like the leadership, you might aim for compliance, but what we really want is commitment. Well, for healthcare, what we're aiming for is to be able to have healthy, cured individuals. But if we can do that in an aggregate manner, we can have higher levels of population health. Maybe we can get there too with energy.
One of my classes posed or posited the question: if you were an operations manager in a healthcare system, would you prefer to utilize just-in-time stocking, or I think stock to supply, just to have a longer-term reserve? And I think the correct answer is just-in-time, as close as you can get it. But I also think about our own healthcare systems. U of L Health Trauma Center, who I've worked with before, that trauma center is a level 1 trauma center, and it's one of the only ones in the entire region. And one of their pride points is that on any given day they can handle a single casualty all the way up to a mass casualty event, as we saw with Old National Bank, the UPS flight that just went down just over the last 2-3 years alone. Let alone the factory explosion that we just had, I think last year.
Yes.
Maybe. So it's an incredibly complex puzzle that has so many different variables and so many different factors at play.
I lean into my own Baylor Masters in Health Administration program. I'm an Army Baylor alum, and the classic Baylor answer, from a military perspective, takes a contingency approach. It depends. And so, to your point about just-in-time inventory, lean processes, I think you have to, one, go to your mission. Like, what is your primary mission, either as a service or as a facility, healthcare facility? And if there is a case that your part of your mission is responding to substantially like second and third sigma events, that yes, you probably should have a shock. The other thing is you have to know your own financial standing. Can you afford to have some level of inventory or medical supplies that might age out and that become wastage?
Or expire.
Right. And so the federal and state government serving the people in our communities is naturally more enabled to be able to take that financial risk. A small community hospital in rural Kentucky, yes, they may be the critical access hospital, but they might not be able to take that risk, though they may want to. And so they need to be lean. They don't need to put themselves in a position where trying to think of the 1 to 5% chance cost them the ability to provide services on a continuous 95% basis.
Well, I've got two kind of closing questions for you, and then we'll start to wrap things up a little bit. Specifically, I'm curious, at this stage, I don't think anyone can necessarily say, long term, this is what we think health administration is going to look like. But generally speaking, in the short and medium terms, what do you think the future of health administration looks like? And then more specifically, how does U of L's online MSHA program prepare students for that short, medium, and eventually long-term future?
Look, healthcare is a resource-intensive field. The prime resource in healthcare are people: physicians, nurses, allied health professionals, administrative specialists, emergency technicians. A graduate of a Master's in Science and Health Administration program, a leader in health administration and management, planning, organizing, leading, controlling, needs to be an effective leader. And so from an organizational perspective, you need to know all the elements of management, know finance and accounting, strategy, operations management, logistics, marketing. You need to be able to communicate. And you need to be able to have a sense strategically, why do we exist? That's the core mission, like perspective. From a vision perspective, what do we aspire to do? And to be able to establish and live values that reflects your society, your organization, your community, to be able to lead that prime resource of healthcare. People, human beings, your teammates, serving other people. And so in our MSHA program, we develop public health leaders. They take a population health management perspective. They work in all types of healthcare organizations, whether or not it's a hospital or health system, health insurance, logistics, primary care, specialty care, federal government. We even have some folks that work in entrepreneurial pursuits. Of course, there's finance and accounting as well. But each one of those individuals has base training and development competencies in healthcare management, but we aim to take things from a perspective where they lead. That when they are on spot, these MSHA cardinals have a sense of what works in an organization. They know the managing elements, but they think of the considerations of others, taking a servant-based leadership approach within the team in a similar manner in terms of the community that they serve. And so that's what I see the future of health administration is that we need competent, invested leaders that earn commitment from the members of their team, and they earn a commitment to a higher levels of public and population health in their community.
If you're thinking about the typical prospective MSHA student, what would you want to encourage them about our program? What would you want to encourage them about online learning?
So there's a couple of things. Our program online is primarily focused for access. Look, there's a lot of working professionals out there. And working professionals could look like someone who is currently an associate or a technician. They're working in the healthcare field, and they like to be a supervisor or a manager, and then ultimately a director. It could take the form of a healthcare provider, a physician, a nurse, a medical professional in technology, somebody that has their own group practice or their own clinic, and they want to have a higher level of competencies in healthcare management, being able to develop a budget, develop a strategic plan, conduct an analysis, understand health policy and how it impacts the organization. So working professionals could be at the administrative, the cleric, entry-level manager, somebody with at least, of course, having a bachelor's degree in order to be able to earn this master's of science in health administration. When we think of serving these group of individuals, we know they're working. They have families, they have a life, personal and professional, and so we've created these online courses in 8-week formats. So we take the content of a traditional semester, the fall or the spring, and we distill it to the critical competencies in an 8-week period. So you get the full course content, but in a concentrated manner. And so students in an 8-week semester generally only take 1 or 2 courses. They can take up to 3 courses in an 8-week term instead of taking a traditional semester where they may have 3 or 4 or 5 classes at a single time. And so that modular effect allows students to, we call it, you can either mash on the gas or tap on the brakes as needed, depending upon you have a life or working conditions that either enable or disable you to be able to take more or fewer courses in a particular 8-week term. The average student in our program, our online MSHA program, graduates in about 2 years. But the nature of our 8-week courses, we have 5 8-week terms, a fall 1, fall 2, spring 1, spring 2, and summer. We always start students in the fall in our current configuration, but students can take courses through the year, and we have students that typically graduate either in the fall semester or in the spring or summer, depending upon the number of courses they take. We have some students that could graduate from the program in as quickly as 1.5 years, but on average, about 2 years. The university allows up to 5 or 6 years, depending upon your circumstances, to complete a graduate degree. And so, of course, the most important thing is we want these folks to graduate, to be able to go out with the credential, to go out with that full training, education, development, that fullest level of competencies to serve as a leader in their own organizations. The vast majority of the students that start our program finish our program. And I think that's a credit to working professionals that have a clear view of what they want and how a accredited top-tier MSHA program fits in their life and career.
I think there's something also to be said about the level of resiliency that people in these programs typically have. It's not an easy thing to say, hey, guess what? For the next 2 years, you're going to be spending hours each night or throughout the week doing schoolwork. You'll have family obligations. You'll have professional obligations. You're going to have to juggle it all.
Connor, I think that's right on track, but it also speaks to being a leader.
Absolutely.
The individual, the professional that's doing the work, being a good teammate at home and in the workforce, and that is able to effectively complete the graduate level coursework. Look, there is positive rigor. We don't want you just to come into our programs to be able to complete the assignments and check the block, hey, I'm good. We're going to positively push you. We want you to think and consider things from a perspective of analytic thinking to maybe reconsider. In some cases affirm. Look, everyone that comes to our program, that rare is they're a blank slate. We want to build upon what you know already and what competencies you bring and to reach you to a higher levels of competency attainment so that you can have that professional fulfillment. And so, yes, that resiliency is a credit to those students, but I think it's also part of the professionalism and dedication to being able to serve people competently, and that resiliency is actually a very critical element of being an effective leader, particularly serving a group of people that often come to us sick or injured or stressed, and of course their families, come with them, and you serve them as much as you do the individual patient or beneficiary.
Before we wrap up, do you have any closing thoughts or anything more you'd like to share?
Look, I think that I told you that I'm a farmer. I grew up on a family farm, played football. I'm a Meade County Green Wave. And when I think about the future, I did not necessarily want to be a farmer, but I truly appreciated the work ethic that my family instilled upon me. It provided me a basis, to be able to know that, a couple of things, that all things are possible. You can dedicate yourself, your life, your family, your faith. All of these things can have a fulfilling life. And so when I think about the work of health administration, I think that for an individual that wants to dedicate themselves to serving people, and look, there are many folks that think about healthcare and whether or not they don't want to practice, medicine, whether or not it's syringes or surgeries or medical, but you want to serve in a medical field. The career of health administration, health leadership is incredibly fulfilling, both personally and professionally, because you're part of a great team of highly educated, dedicated people that are similarly focused on improving health, improving communities. Again, I referenced that American College of Healthcare Executives, Congress, like 7,000 professionals from all across the country. And despite all of these things that are going on in our world and our society, in all levels, folks that were dedicated to a great life of service. And I didn't find anyone that was downtrodden. There's always some case of like cynicism or being guarded against things that emerge that it might impact your team or your organization. But the net effects are folks tend to take a glass half full perspective. And as long as we have people and as long as we have a society and as long as we're all in this together, I think a career in health administration and leading healthcare delivery is a great place to be. And, I'm happy to be here at the University of Louisville on this team, to create those pathways for development to see our Cardinals shine.
I think that's a perfect place to wrap things up. Lee, thank you so much for your time. Thank you all again so much for your time, and thank you to you, the listeners, for joining us for this discussion. The University of Louisville offers over 70 online programs, which include bachelor's, master's, doctoral, and certificate programs designed to allow you to complete your degree on your schedule. There are transfer credit and scholarship opportunities available for many of our online programs so that you can save time and money on your education. If you'd like to learn more about the online Masters in Health Administration, you can click the links in the description of this episode, or you can learn more at uofl.me/obnapod. Again, that's uofl.me/obnapod. Thank you again to Dr. Bewley for joining us, and I hope you all have a great day. See you all on the next one.